So LixiLan-O was as an add-on to oral agents in patients with type 2 diabetes not controlled on metformin plus a second oral agent. And so they took these patients who were on their orals. They had an initial run-in. I think all the other agents were stopped except metformin. And then they were randomized to either lixisenatide, glargine, or iglar-lixi. And as you can see here, clearly the best hemoglobin A1C achieved was an average of about 6.5% with the iglar-lixi combination, starting from a baseline A1C of about 8.1%. But you see that most of that benefit came from the postprandial glucose reduction of almost 42 milligrams per deciliter when you have a short-acting GLP-1 receptor agonist like lixisenatide included in it. And of course, the weight change is always going to be an intermediate between GLP-1 by itself and insulin by itself. So you do minimize some of the weight gain you have as if you were to continue to titrate the basal insulin. And the percentage of patients who reached that A1C goal of less than 7% at week 30 were clearly favoring the iglar-lixi combination. And as we talked about before, that magic combination of A1C less than 7% with no weight gain and no symptomatic hypoglycemia clearly favored the iglar-lixi component. And as we look at adverse side effects, I always like to point out the GI side effects. The number one limitation for use of GLP-1 receptor agonists is nausea. And in most clinical trials, you'll see that between 20, 22, 24%. And for lixisenatide, that's about 24%. Yet for the iglar-lixi component, it was only 9.6%, right around 10%, which is markedly lower than what one would expect for a GLP-1 receptor agonist by itself. And as we have said before, most of the thought about this is as you titrate the basal insulin component, the GLP-1 receptor agonist just rides along with the insulin, in which that smooth, slow up titration without jumping between doses that we think really minimizes the GI side effects. And in this case, you can see that that held up.